Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is John Moore, founder of Chilmark Research. Over 10 years ago, John pivoted from advising global companies in the manufacturing sector on IT adoption and deployment and opened the doors at Chilmark Research, which he has built into a leading healthcare IT analyst firm focused on some of the leading-edge issues in the industry, ranging from backbone issues like health information exchanges and cloud computing, to analytics, to remote monitoring and telemedicine, and other patient and consumer engagement tools and trends. Welcome, John, and thanks for joining us.
Oh, my pleasure, David. Thank you for having me on your radio or podcast talk show here. Looking forward to it.
So, John, value-based care is one of those things that we keep hearing about. I've been reading reports and predictions about value-based care for at least a decade. And all sorts of folks have been saying for years now that the shift from volume to value will be transformative for healthcare. And yet here we are. ACOs, which were supposed to be a key manifestation of this trend, are barely saving a half penny here and there. Many individual players in the ACOs and bundled payment demos and other value-based care experiments are ultimately being paid on a fee-for-service basis at the end of the day. And so I have questions, a lot of questions. I assume that you, like me, would like to see value-based care succeed. And I'd like to understand from your perspective what needs to change in order for the promise to be realized. So let me unpack that a little bit. So first, what is the promise? And second, are the policy building blocks in place? And are the things in place or being put in place sufficient to change human behavior? And third, are the technical building blocks in place? Feel free to take those in any order, John.
Okay. Well, unpacking value-based care is really, it's like a accordion knot of sorts. There's a lot of different things tied up into that. And I think one of the things we have to kind of step back and realize is that when we look at healthcare and how healthcare is being paid for today in the United States, it's been predominantly a fee-for-service model. And that fee-for-service model has been recognized by just about everyone, economists to politicians to even people that work in the healthcare space, is unsustainable. And therefore, that's why we've tried to move towards value-based care from fee-for-service. The challenge has been provider readiness. How do we get providers to actually change the practice of care and how care is actually built? Because today we really have not health care, but sick care, where we only worry about people when they're sick, and then we start the ticker and collect the money. We're really not looking at how do we keep people well. And the move to value-based care is trying to move, again, to a model that is not so much disparate care, but integrated care and lifetime care that helps people actually manage their health better and help bring down the cost of care and deliver value at the end of the day. It's the three things that were core to the Accountable Care Act, and that was access to care, cost, and, quality of care. So that's the objective. Now,
it sounds like we need a bunch of both tools and kicks in the pants to get there.
Well, yes and no. I think, in our research at Chilmark, we've been studying this because part of the whole Meaningful Use Act and the High-Tech Act was to basically provide physicians and hospital systems with the basic digital tools that would help the whole industry move towards value-based care by being able to actually measure the quality of care, the outcomes of the care that's being provided to patients. Now, if you look around the country, one of the things we find is that there are pockets where value-based care is occurring and organizations that are aggressively moving ahead. Unfortunately, you could count them on both hands. There's just not a lot of organizations that have made the commitment to make that migration to value-based care. I mean, last year we had a speaker from Geisinger, and he is the chief medical officer for the health plan side of Geisinger, and also is the CMO for their population health for all of Geisinger. And the title of his presentation was Burn the Boats. And he made the argument during our conference that what organizations need to do is make the commitment to value-based care, set sail to the other shore, and once they get to the other shore, that shore being value-based care, burn the boats and don't go back to fee-for-service. Because it is such a cultural change for organizations. You can't reverse yourself. You really have to go in with everything, with the whole organization behind it, with the executive support all the way down through the ranks to make this conversion, because it is very much a cultural change as much as anything.
Right.
Culture eats technology for lunch. And, it doesn't matter what technologies you may put in place to kind of enable value-based care. I mean, here we are as an IT analyst firm. That's what we study, is the technology side of things. But you have to put that in the context of the culture of the organization. And if you don't have the culture behind it, your technology investments will fail.
So we need to make that cultural shift, I guess, in order to make any progress. In the past, I've seen organizations that had both value-based and fee-for-service contracts in place simultaneously. Obviously, it's difficult to work on both sorts of things at the same time and take a different approach with different parts of your patient panel. And for many providers, that just means sort of picking one approach and using that. And if we pick right, then we've picked to approach things in a value-based sort of way. And folks who are not under an ACO or other value-based contract get the benefit of that treatment. Hopefully we don't have people taking the fee-for-service approach in that context and ending up with the worst of both worlds.
Yeah, well, that's the hope. But I think you also have to look at, when you look at some of the organizations out there that have already moved in this direction, for example, Advocate in Chicago, they have over 500,000 lives that are in a capitated model of care. So they have fully embraced, or they have embraced, not fully because they have a lot more patients than that, but they have a significant portion of their patients in value-based care and a value-based contract under that capitated care model. And they've made significant investments to make that happen, both culturally and technologically across their organization. And they're, in some respects, a leader in moving ahead in that regard. And what's surprising is that they're a very large hospital system. If you look around at the value-based care and where it's had more success, it's been traditionally around smaller physician practices, IPAs in the ambulatory sector, whereas hospital systems seem to struggle more just because I believe it's really because of the inertia of a hospital system.
Right. I would agree in what I've seen that the sort of physician-led initiatives, as a rule, I'm sure there are exceptions, are likely to be more successful on this front because we have, the old adage that the most expensive instrument in healthcare is the physician's pen. And if we get the attention of the physicians, then maybe much of the rest will follow.
But it's also looking at the one of the problems we have here in the move to value-based care in some respects is looking, for example, at the specialist. I recall speaking to the head of cardiology at a very large hospital system in the Midwest, and very well respected, well-known hospital system. And the head of cardiology basically told me if his surgeons want to be paid just on RVUs, which is a fee-for-service model. They don't want to be tied up into bundles. They don't want to be responsible for anything. Then they come in, they do their surgery, they move on, and they get paid for each surgery that they do. And he said it's a real struggle to try to get them to think or accept a move to value, and that their reimbursement will change based on outcomes because the surgeon doesn't believe they have any responsibility beyond doing the actual surgery. Right. And he said if he tries to hold them to that accountability, they literally up and leave, go down to the street to the next competing hospital system, and they're instantly recruited.
So do you think that it's possible to wrap a value-based environment around a fee-for-service relationship with physicians like that? Because that's not a unique situation. I mean, that happens in many places today.
Oh, yeah. It sure does.
Or do you
I think that gets to the culture.
Is the ultimate goal crossing the sea and burning the boats, or can we live with this middle ground?
I don't think we know yet. I think currently in today's environment, competitive environment, particularly in markets that are highly competitive, you're going to see some of that still occur. I believe over time, if organizations really jump on fully with value-based care, that these surgeons won't have any place to go. They're going to have to just accept the fact that how they are paid is going to be different than the way they are paid today. But I think that's going to take several years to work out. Okay. Because today, with value-based care, as much talk, as you did in your intro, as much talk as there's been over the past decade or so on value-based care, and everyone's speaking to, how much of, say, CMS spend is going into value-based contracts, et cetera. When you get right down to it and look underneath the covers and look at a hospital's revenue, it still represents, maybe 10% of total revenue. So it's not enough to really influence the decisions of the CFO and the CEO yet.
Right.
I think another issue we have with the relative success or lack thereof with some of the early value-based contracts and ACOs that have been out there is, well, actually it's twofold. First, many of these contracts really had no downside risk. So for the providers, it was all upside. They didn't have anything to lose by going into these contracts. They weren't going to lose money. They weren't going to have to pay CMS back. It was just upside or a zero-sum game for them. Secondly, is that we still don't have kind of universal, globally, or at least nationally accepted metrics to measure value. And we try using it with a bunch of quality measures, which are typically process measures, but they're not outcome measures. We have not been able to develop systems and methods and metrics to measure what value is and have consensus on that. There was a recent study done at the University of Utah where they looked across the provider, did a survey across the provider community of how do you measure quality, and they couldn't find any consensus. Even amongst physicians, they do not have consensus as to how one measures quality. So if you don't have that basic metric, how do you measure value? And I think that's been a real problem for CMS in trying to measure the value of care delivered in these value-based contracts, and it's led to a lot of angst amongst provider organizations in terms of the plethora of quality measures they have to report out on for these different types of value-based contracts.
Yes,
whether it's commercial contracts or it's federal CMS type contracts.
Certainly a plethora of measures. If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is John Moore of Chilmark Research. So back in the bad old days, staff model HMOs were all the rage, and for years my family got our care through a staff model HMO in the Boston area. I thought it worked really well. Then the HMO spun off the physicians, and then later the largest physician group established a goal of being at risk under all of its payer contracts. So we've sort of come full circle. And whether or not folks have followed the same sort of path, a lot of healthcare organizations are now arriving at a payer-provider convergence. And payers are providing a whole variety of services, preventive and case management services through clinically trained staff. And providers, like my doctor's medical group, are assuming risk. So there's this convergence of payer and provider functions and crossover of functions. What's going on here? What's your perspective on this? Is this an overall trend that you see in the industry? And where are we headed with payers acting like providers and providers acting like payers?
At Chilmark Research,
Yes.
we developed a thesis called Convergence. Basically the thesis was providers and payers must converge to be jointly successful at value-based care. That payers need providers to deliver the care, providers need payers to assess the risk and understand the actuarial risk of the patient panel that they were taking on and be able to identify the gaps in care as well as where, say, a patient may be getting care elsewhere outside of the network. So with that in mind, we believe that providers and payers need to come together, and there's a whole bunch of inefficiencies today in typical provider-payer contracts and interactions. The prior authorization process is a case in point. What would happen if two organizations, a payer and a provider, got together and had developed a level of trust where the payer said, we don't need to do prior auths with you, the provider, because we trust what you're going to do is going to be the right thing for our members. That takes off a huge burden from providers, and it helps facilitate, I believe, better care processes in the end because of that level of trust. You're starting to see this happen more and more across the country. Last year, Aetna signed a number of deals, joint ventures with large provider health systems around the country, where the board is made up of half Aetna representatives and half healthcare system representatives. And they have a CEO, and the CEO runs that JV. And Aetna basically turns over its book of business in the region or catchment area of that given provider, and the provider manages that whole member panel for Aetna. They've been doing this down in Virginia for a while, for a few years with Innova Health. And now they've got these relationships with Sutter, Texas Health Resources, Alina, and the last one is Banner. If you look at United Health, they've kind of taken a different tack to this. The United Health Group has been more acquisitive in acquiring physician practices, as well as an ambulatory surgical center. And they're kind of, I would say, looking to really deliver the care directly to members in different parts of the country. And by that, they are becoming a provider themselves, which is not unlike what, Kaiser Permanente has done for decades in California. They are a provider and a payer. UPMC in Pennsylvania has been doing the same thing. And we have seen providers try to stand up their own payer initiatives or their own payer group, but it can be very difficult for providers to actually support that because the level of risk and distributing that risk over a patient population, you need a fairly large population to be able to balance the risk. And most providers do not have a large enough region or catchment of patients/members to distribute that risk.
Right. So do you see Aetna and CVS Minute Clinics as another sort of a new frontier in this department?
Yeah, it'll be interesting to see how that works out. CVS Aetna, I could see them becoming in some ways similar to, but not quite as into healthcare as, say, United Health. I mean, United Health, with its purchase of an ambulatory surgical centers, has gone right after specific service lines that are very profitable for hospitals, e.g. orthopedics. Whereas, CVS, when I've spoken with them and what they're doing with Aetna, they're really looking to become the front door to care for the basic care and urgent care needs, and then also working closely in partnership with local providers to be able to hook those patients up with the local provider community that they have a partnership with to provide secondary services.
Right.
So I don't see them as quite so aggressive as United Health in terms of displacing the local hospital systems. I think they're trying to work more in concert with those systems.
But do you not see that as working to establish a narrow network, having the front door lead to a narrow network that would then sort of do what we sort of expect payers to do sometimes in order to control costs, as opposed to paying for everything everywhere?
Oh, absolutely. I mean, they're already establishing narrow networks anyway, because they're looking to provide a level of quality and service in terms of the provider networks that they can provide to their employer contracts. And if they can go to the employer and say, look at us, we've got these great network in the regions where your employees are, that's pretty attractive to an employer that has employees distributed across the country. I was talking to one employer who made the switch from one payer to another just because of how aggressive the other payer was in developing high-performing networks.
Sure. I mean, it makes sense if you're really looking at this carefully as a payer, as the employer here.
Mm-hmm. But when we go back to value-based care, I think that's one of the things that's been a little bit challenging here is that the employers have not been as quick to embrace the value-based care models. You see little pockets of it done around specific, very expensive procedures like cardiology, where maybe they'll choose the centers of excellence to send their employees to. But that's about the extent of it. They haven't really fully bought into it. They talk about it, but you haven't seen them move quite as aggressively as CMS. And, most people by and large do see CMS as leading the charge here. And since the federal government represents over 50% of healthcare costs, in terms of reimbursements, it's not surprising that people would look to CMS to help lead the way because they are national. They're in every state, every region of the country, and they do have the clout to potentially move the needle.
Do you see the employers coming along anytime soon?
Oh, sure. I think they'll be fast followers, though. I don't think they'll be the ones leading the charge, except for, it's kind of like I talked earlier about providers. There's only a handful that have been aggressively pursuing value-based initiatives like an Advocate or a Geisinger or, Kaiser Permanente has been doing it forever. But on the employer side, again, it's only a handful of organizations in the employer space that have been able to really try to do something. And, part of the problem with the employers is that they don't have a critical mass in any one area to be able to really push providers to do something. At least that's the case in many parts of the country, in most parts of the country. There are places like in Seattle where Boeing's been able to do some very aggressive contracting with the local hospitals. The same is true in Detroit with GM and Henry Ford. Mm-hmm. GM and Henry Ford just signed a big agreement in that regard. So you see pockets of it, but it's not like it's universal. I mean, even the much touted healthcare transformation task force that was formed by a number of large employers, they've been in existence for several years now, and they're only now this year rolling out contracts in just a couple of locales.
Healthcare is hard, as they say.
Yes, it is.
Who knew?
Who would have thunk it?
So, John, if you were to wake up in 5 years from now, what is one thing that you would hope or expect would be different from today, something that may have changed drastically from today?
I believe that, waking up 5 years from now, the thing that comes first to mind is that we will have much better tools and data to understand where health is being provided, what kinds of clinical pathways work best, and being able to remove variance, unwarranted variance in the healthcare system that contributes to cost.
Sounds good. I'm in.
Okay, so am I. I hope that's in 5 years. I'm not going to hold my breath, though. I got to tell you, David.
Okay.
We've got some pretty big challenges ahead of us.
Mm-hmm. Well, thank you, John. I appreciate you taking the time to join us.
You're very welcome, David. This has been fun. Really enjoyed it.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.